السلام عليكم يعطيكم العافية ورمضان مبارك على الجميع. In this lecture we will continue what we started 2 weeks ago. 2 weeks ago we talk about acute ischemic stroke management, and we will continue with the counterpart of it, which is ICH. So we will cover a couple of things, started from the epidemiology, pathophysiology. It's really happening. Yeah, epidemiology, pathophysiology, clinical presentation, diagnosis, and treatment. These are the outlines, and we will go right now from the epidemiology. So start with the epidemiology. As we mentioned in the last lecture, we said that 85 of the stroke are ischemic and 10 to 15 are hemorrhagic stroke or ICH. The incidence of ICH is 24.6 per 100,000 person in a year, and the growing incidence over all the globe because it's related either to anticoagulation, antiplatelet use, or aging population. It's more common in male, more common in African American and in Asian. And when we grow older, more than 55, the incidence of ICH increase. This is about the epidemiology. Pathophysiology, with the sustained chronic hypertension, the penetrating arteries will form a small aneurysms. With increasing and long-standing hypertension, these aneurysms, which we call the Bouchard aneurysms, will rupture, leading to the primary ICH, which is related to hypertension. So pathophysiology is related to rupture of Bouchard aneurysm and hypertensive bleed, and the primary ICH is either related to hypertension or amyloidangiopathy, cerebral amyloidangiopathy. And we have secondary intracerebral hemorrhage due to either medication like antiplatelet, anticoagulation, sympathomimetic drugs. Usually they are young who are intoxicated, and they came with hypertension and ICH. Secondary hypertension also related to vascular malformation, vasculitis, sinus thrombosis, or hemorrhagic transformation in a stroke, either spontaneously or related to our management, as we mentioned in the last lecture, like IVTBA or thrombectomy. Sometimes neoplasms could be complicated by ICH. So usually what we see in the ICU, the hypertensive related ICH, rarely we see these, but we see in the secondary part, we see the vascular malformation and CVST. Stroke and hemorrhagic transformation through stroke, we will see it in the patient who receive IVTBA more frequently if they are late in the window. So the etiology of ICH, either primary or secondary. The primary is related to hypertension and amyloidangiopathy. Secondary is related to either something coming outside the brain or something inside the brain. Inside the brain is either vasculitis, vascular malformation, stroke, or CVSTs, or a neoplasm like GBM, or other neoplasms like lymphoma and leukemia. Secondaries are related to medication, antiplatelet, anticoagulation, or sympathomimetic drugs. That's why history is very important in approaching patient with ICH. So clinical presentation of ICH, we know the skull of the human being are very small, and they are contained within three structures. This is the brain, which is the brain, the CSF, and the blood. When any increase in the volume of any of these compartments, there will be a compression in the other compartments. So if there is an increase in the volume of a new volume, or increase in the volume of other compartment, will lead to compression to brain tissue. For example, if there is increase in the CSF, like in hydrocephalus, will be compression on the brain parenchyma. If there is increase of the blood, or a new volume like a blood in the brain, which is not that elastic, there will be a compression on the other part of the brain, leading to increasing in the ICB, leading to symptoms like headache, nausea, and vomiting, and sometimes loss of consciousness or decreased level of consciousness. Focal neurological deficit relating to where is this hematoma is located. So if it is located in the right hemisphere, will lead to focal neurological deficit in the left side. If it's related to brainstem, will cause coma. If it's related to occipital lobe may cause blindness. And associated symptoms like it can relate to the primary cause of the ICH. If the patient is elderly with cognitive impairment, this possibly related to amyloidangiopathy. If there is increase in the blood pressure, possibly this is hypertensive bleed if the patient is really already hypertensive. If there is association with other complication of the ICH, will be a seizure. The clinical presentation of the ICH and the stroke are the same. We cannot differentiate by history or physical exam. Yes, we have some clues, but these clues could mislead you. So in a stroke, we have patients who will came with nausea and vomiting and with high blood pressure readings, especially if they have malignant stroke from the beginning. So the clinical presentation could mislead you sometimes, and there is an overlap between ICH presentation and the stroke presentation. Yes, the seizure upon presentation most of the time related to ICH presentation. The diagnosis of ICH, the diagnosis of any medical issue, history and physical examination. In the history, you have to ask about risk factors, triggers, onset of symptoms, and if the patient has hypertension. Investigation, ECG is very important because sometimes you will see T inversions in these patients. Sometimes the ECG patient, sometimes like especially in subarachnoid hemorrhage, people see T wave inversion in the ECG. They think it's non-ST elevation MI, and they give anticoagulation and made the scenario of the patient worse. If the patient coagulation profile, if the patient on anticoagulation like warfarin, you have to add you have to do INR, BT, and BTT. CBC toxicology screen usually in the young who had no risk factor. Imaging, we will do CT and CTA, and we need sometimes an additional tests like MRI and MRA in special occasions that we will mention later on. We will depend on a couple of prognostic indicators or prognostic factors in these patients like ICH score. ICH score, it's help you to communicate with other services, other hospitals if you want to transfer your patient. It's not to end the care of the patient. It's only a part of the communication and how you communicate also with the family. So you don't, at least you give them the real or the reasonable scenario or the reasonable outcome for this patient without any care if anything happened to this patient. ICH score, we have 5 parameters in this scores. Couple of them are clinical and couple of them are radiologically related. So the GCS of the patient is very important upon a presentation on the patient with the ICH. The GCS is one of the prognostic indicator at what is the strongest prognostic indicator. If the patient came with a GCS of 13 to 15, they will take 0 points and their functional recovery will be higher, except if they deteriorate later on. 5 to 12, they will get 1, and 3 to 4, they will get 2. And 3, if the patient is presented with GCS of 3 and there is no IVH, that means there is no reversible thing like IVH and hydrocephalus, this patient will do so badly, and their death rate will be like 99% in the couple of days of their presentation. Age of the patient younger than 80 or more than 80, location infratentorial, if it is pontine and brainstem stroke or cerebellar, they do worse if there is no surgical intervention in the cerebellar part. Supratentorial, we will go through their prognostication or what we should do to them. ICH volume more than 30, less than 30, and this is came for the surgical intervention in these patients. Intraventricular blood, yes, if they get 1, but if you take this blood out, you will decrease their score. And this is the 30-day mortality of these patients according to the ICH score. 0 will be 0, 1 will be 13, 2 will be 26, 3 will be 72, like triples the percentage, 4 97, and 5 and 6 100% death within 30 days. And we have another scoring system for the functional outcome for this patient also, yes. Divided the volume more than 60, age 70, 70 to 79, and more than 80. And location to lobar deep or infratentorial. Infratentorial, we mean the brainstem and the cerebellum. GCS of the patient more than 9 or less than 8. If there is any history of ICH and cognitive impairment before this ICH, that can correlate with amyloidangiopathy. And if the higher the score, that means the good outcome, the lower the score, the poor outcome the patient will have. So we cover a couple of things that you will read it in a couple of articles, and sometimes in the neurology aspect we have a question in this if we want to communicate with the family in breaking bad news. And the ICH score, you will see the volume. So how can I calculate the volume of the ICH? The volume of the ICH is calculated in a formula, which is A multiplies by B multiplies by C divided by 2. So what is A, what is B, what is C? A is the long uh, diameter of the hematoma. B is the perpendicular line on the lung diameter, and C is the number of the cuts that has the hematoma and multiplies by the thickness of the slides. And usually the thickness of the slide, you will see it in the bottom of the CT screen when you are scrolling the images. They will write 5 millimeter, 6 millimeter, 2 millimeter, and all of them should be with the centimeters. So you multiply them and divide it by 2, you will get the ICH volume. So I think this is the basic that you should cover of the ICH. So this, we spoke about the ICH score, we spoke about the functional score. These scores, they were validated in patients who had no intervention before. So if we are intervening with these patients, either surgically or minimally invasive, as these scores are validated for them, there is an article that has been recently published in Neurocritical Care Society in I think April 8th. They said the current prognostic tools of patients with intracerebral hemorrhage remain limited and maybe overestimate the risk of poor outcome in patients who receive a treatment like minimally invasive or craniotomies. So still we need a validation for these scores in the patient who received surgical treatment rather than only medical treatment. So this is, we conclude part of the prognostication. Now we will go to images. Yes, I received one patient in the emergency department. I think it's a they will call you as a stroke code. So I will do an imaging. What the imaging will help me? The imaging will help me in location first to distinguish it as ICH or it is a ischemic stroke. Location and mass effect. I can calculate the volume from the image. I can predict the hematoma expansion. So this is the benefit of the the regular CT scan, the non-contrasted CT scan. Will give me the location. It is supratentorial, infratentorial. If there is any mass effect like compression on the other hemisphere, compression in the lateral ventricle, herniation like ankle herniation. I can calculate the volume as we mentioned. Prediction of hematoma expansion. We can predict hematoma expansion from non-contrast CT scan, and we can predict it from contrast CT scan, and we will see in a couple of the slides. So this is you will see 6 images of ICH. So is the etiology of this ICH is the same? Because we said that ICH, CT scan, can give us a hint about the etiology from the location. So if we see this hemorrhage, it is deep. It is in the basal ganglion. This is if you look to the normal side. This is the lateral ventricle, the frontal horn of the lateral ventricle. This is a small, tiny particle here. This is the head of the caudate. After that, you will see something like a triangle. This is the putamen and the globus pallidus. We call it lentiform nucleus. And in the other side, you will see a bleed here. So the bleed here is in the putamen or the lentiform nucleus, and this is the most common sign of bleeding related to a hypertensive bleed. So it is deep. The most common site is the putamen. Yes, this is the most common type, followed by ICH in the thalamus, followed by ICH in the cerebellum, and pontine. So these four are the most common. Later on come subcortical and lobar. Okay, so the most common site of hypertensive related bleed is putamen, and deep. After that, the thalami. After that, the cerebellum, and lastly will be the pontine. These are least to be common. If I saw this, maybe I will think about a tumor first, then ICA, and then hypertension. If I saw this, maybe I said, yes, this is possibly deep bleed, like thalamus, and dissected to the uh, ventricles. And in here, in these two, I have to rule out vascular malformation, especially if the patient is young or a tumor. So these are the most common causes of the most common site of hypertensive bleed: putamen, thalami, pontine, and cerebellum. I'm sorry, bones and cerebellum. So from the CT scan, as a neurologist, I can say this is possibly like 99% related to hypertensive bleed. This is, I will be questioning and asking for further imaging like CTA or MR later on. And other type of hemorrhage, like primary hemorrhage, is the or spontaneous hemorrhage, we call it, is the amyloidangiopathy, cerebral amyloidangiopathy. You will see like honeycomb appearance. It's multiple sites, multiple ages. It will be cortical and subcortical. It will be like sunrise, like it will be spread from the cortex to the subcortical area, with the mass effect will be different ages also. This is the amyloid angiopathy, and you can, by history, if the patient is elderly, having some alteration of mental status, like they are start to be dementic, increase in forgetfulness, they don't remember only the old things. So you can relay, and this is possibly related to amyloid angiopathy. And these patients, don't touch them surgically, the amyloid angiopathy patient. Etiology and the prediction of hematoma expansion, as we mentioned, we can predict in the CT scan, we can predict the hematoma expansion. Yes, we can predict, and we have a couple of signs in the CT scan give us hint that this bleed will expand in the coming hours. Why we are afraid of expansion of hematoma? Because expansion of hematoma, that means more mass effect, more increase in the ICP, more compromisation in the normal tissue, and more worsening in the outcome of the patients. So CT will give us a hint because we have a couple of signs, like a blend sign, and we will see it in the CT scan. Blend sign is like you will see the hematoma having multiple densities. Black hollows, like a hematoma with a small dot in it, Iceland sign, and the blend sign, they are almost the same, but the Iceland sign, it will be a clear cut between the two densities or the two hematomas. Hypodensities around the hematoma and within the hematoma. CTA, it will give us if there is any vascular malformation, and it will give us if there is any spot sign. The presence of a spot signs increase the mortality of the patient by 33%, and it will increase the hematoma or the hematoma expansion about 16 ml, and that's very worrisome if you see it in one patient and you didn't do anything. MRI will help us to see if there is any microbleeds in patient with cerebral amyloid angiopathy, if there is any underlying neoplasm, and if there is any vascular malformation. So we will go to the next images, and we will see the CTA and the CT, and we will see the signs that can predict the hematoma expansion. If you look at this part A, you will see a hematoma having multiple densities. Like this is very fresh, like a bone density, and this is a fresh blood. This is an old blood, and this is like they are blending to each other, but there is no separation like this. If you see this is an Iceland sign. There is a clear separation between the two densities. Okay, but here these two densities are blending with each other. No clear distinction between them except the color. So this is a blend sign. And in the blend sign, this is a CTA or post-contrast CT scan showing a small dot here. And this is a small dot is the spot sign. It is after giving the contrast of the patient, you image the patient and you will see an area of contrast. There was no blood vessels in it. And this is indicating a extravasation of contrast from the blood and an active bleeding in this area. This hematoma, like 94 will expand to you in the coming hours, and you have to do something. This is the hypodensities that you will see like here and here. Okay, and this is the black hole sign, and this is also a black hole sign. So in this patient, you will say a black hole sign, you will say an island sign. Here you will see a blend sign, like multiple densities that is not clearly separated, and they are blending with each other. And you will see here the spot sign, which is indicating there is possibility of expansion of the hematoma. So plain CT scan is very useful in patient with the ICH. And also CTA is very useful. And what is the indication? To ask the radiologist for CTA. For example, the radiologist will see a hematoma here. Like this is, he will say or she will say to you, this is, I kind of swear to God, will be a hypertensive bleed. Why you will ask for, why you want in CTA? You will say, I want CTA for two things. If they are young, likely younger than 45, and they are not known to be hypertensive, uh, you will say to rule out vascular malformation. And if it is and if it is like more than 45 and they known to be hypertensive, you will say I want to rule the possibility of expansion of the hematoma. So you cannot sleep in patient who had spot sign or these signs in the CT scan. You have to know how to stratify your patient. Is this patient is need for ICU admission or high dependency unit or floor admission? This can give you all this can with the other thing can give you the answer. You have to put it together and you can give you the answer, the clear answer, where should you admit your patient. So from the expansion of the hematoma, we have scores. If they are here, these patients are higher risk to have expansion of the hematoma, like baseline intracerebral hemorrhage. If it is more than 20 ml, they will have expansion of the hematoma. If there is recurrent ICH, these patients will have expansion of hematoma. This patient in anticoagulation, yes, they will have expansion of hematoma. If there is any intraventricular extension, yes, there will be high risk of hematoma and neurological deterioration, either because of hydrocephalus or because of expansion of hematoma. Number of hours to baseline computed tomography, like numbers of hours from the onset of symptoms till patient reach the ER. So the earlier the patient presented to ER from the onset of symptoms, the more these patients will deteriorate and the more these patients will have malignant course in ICH. The later they present, like they have the symptoms, like staggering symptoms, like from yesterday, and yesterday, what was Wednesday, and they presented Friday morning, these patients usually they don't have the probability of expansion in hospital because they already expand at home. So if the timing of the patient came earlier, like the onset of symptoms like half an hour ago, these patients, they tend to deteriorate faster. Blend sign, as we mentioned, any hypodensities, as we mentioned, if time from onset of symptoms to contrast, it is the same. If it is less than 2.5 hours, they will get 2 points, and the score is 0 to 5. The higher the score, the more tendency the patient will have expansion of hematoma. And the problem with expansion of hematoma, as we mentioned, that can deteriorate your patient in a couple of hours from GCS of 15 or 14 to GCS of 3 if you didn't pay attention to that. So if MRI and MRA can give us further information about microbleeds, Like here, you will see like small dots of hypointense lesion, black holes. This is a patient with amyloidangiopathy. And this patient, we will see like a bag of worms, like a small dots everywhere. Like this is the head of the big worm. It's an AVM. So it can give you more illustration and more information of your patient. Now we will go to the real life. This is all about neurology and what you have to understand about ICH. Now we will go to the real action that the ICU resident wants to know. So treatment. Any treatment, as we mentioned in the last lecture, in neurology or in anything, if there is, I have to stop the primary insult. I have to prevent happening of secondary injuries and avoid any complication. So, or deal with the complication is the same. If you put these three principles in your head, you can manage anything in life. So I have to stop the initial insult. I have to prevent the secondary complication or the secondary injuries. And if there is any complication came in my way, I have to deal with it. This is the three principles in any part of the medicine you have to know and you have to apply. ICH is an emergency and it is a neurological, neurosurgical, and ICU emergency. Uh, you have to be calm during the management and you have to be organized and sharp because you don't want to lose any information from the family or any information and you lose the patient because lots of information from the family or the patient can help you in the diagnosis. So if you suspect if the patient presented to emergency department, they will present either with high ICP symptoms, they will present it with seizure, or they will present with a focal neurological deficit. If they present with seizure, the ER, they will see it's an status epilepticus. They will intubate the patient immediately and they will shift to CT scan. If the patient presented, his GCS is fine, but he presented with headache and focal neurological deficit, they will scan him. And upon scanning, they will see an ICH and they will call for help because this is an ICH. This is not a clear scan, and they will announce a stroke code anyway if the patient came with focal neurological deficit. So brain attack activation or stroke code activation. Steam stroke will be paged, CT technician will be paged, neuro ICU and charge nurse or the neurointensivist or the ICU, depending on the setting that you work, should be paged. Initial CT scan done and it shows, for example, hemorrhage. In the way patient is shipped from ER to CT scan, there is a couple of things that the physician can do it before CT scan is happening. What are they? Check for RBS, what we mentioned in the stroke code, check the blood pressure. So checking the RBS and the blood pressure, they can do it spontaneously upon the patient arrival. If you see the blood pressure is very high, sky high, like more than 220 over 110, these are the parameters that you want to treat in stroke patient to drop it to 185 over 110 so they can receive the IVTBA. So there is no harm to drop the patient blood pressure if they came within the window. An assumption, possibly this patient is either stroke, ischemic stroke, or ICH. In the two ways, there is no harm to drop the blood pressure, like to reach 185. If it is a stroke code, patient, okay, you save time and the patient can receive later on the thrombolysis therapy. If it is a ICH, you are doing a great job that you have to drop blood pressure. And dropping blood pressure on ICH patient should be continued in the lower than 180, and we will go to the targets later on. So in the initial evaluation, if you are evaluating any patient who has suspecting to have a stroke code, either ischemic stroke or hemorrhagic, and you see the blood pressure is sky high, more than 220, and this patient coming within the window, what never mind, is it ischemic stroke or hemorrhagic stroke, you have to drop the blood pressure. Check airways, breathing, and circulation because it's emergency. If the patient need intubation, regard these should be intubated. Place an IV, we said at that time 18 gauge cannula, and we will say here the same 18 gauge cannula, and draw for coagulation, CBC, CMP if you want. Supply oxygen if the oxygen is less than 92. Consider pulse oximetry and cardiac monitor, and extract troponin and cardiac enzyme. Physical neurological examination, short, what is and what's there, what the patient deficit. And anything, if you don't examine the motor, I will not be upset, but if you don't examine the pupils, this is the time that you do a big mistake, because a pupillar reaction will be lost in a couple of patients before blowing their pupils. Like we lost the reactivity before changing in the size. And this is the alarming sign. If you see a reaction in two eyes that is completely different, like one pupil is reactive, the other is not, but the same size, this is alarming signs, and this patient should possibly should go from CT to an OR. Non-contrasted CT scan should be obtained. CT scan done and showed an ICH. As we said, we have to drop blood pressure from the beginning, 10 milligram labetalol hydralazine, or to drop blood pressure less than 140, and this should be within 1 hour. The recommendation previously, like the recommendation of ICH management or blood pressure management in the ICH, go in different grouping previously. Previously, it goes with the group of hypertensive emergency. You don't drop blood pressure less than 15 to 20% from the baseline because the cerebral perfusion pressure. Then it goes with the further studying, if we drop the blood pressure because we want to prevent the hematoma expansion, if the hematoma expansion related to, or the hematoma related to hypertension. So then now the recommendation, like most of the recommendation, is less than 140 millimeter mercury. The Neurocritical Care Society in the previous edition recommend 160 to 140 to 160, and the latest edition that was published and will be available in the market soon, they recommend less than 140. Start nicardipine infusion if it is there. If your patient is asthmatic, you will avoid labetalol, you will start calcium channel blocker. If the patient per history is in warfarin or NOACs or other anticoagulation, you will they should receive the reversible agent, aiming for an INR which is normal, which is uh, complete reversal of the INR. If there is a brain edema or mass effect, mannitol could be started, or hypertonic saline started peripherally and shift to central line. If there is any surgical intervention or surgical indication, no, patient should be admitted to the ICU because they need a close monitoring for their blood pressure. If this patient surgical candidate and the surgical candidate, we will have an absolute surgical candidate, and some people that is an individualized call. A patient with cerebellar hematoma more than 3 centimeters and compression on the fourth ventricle, this or brainstem, they have to go for decompressive suboccipital decompressive craniectomy. Patient with IVH and hydro, they should go for AVD insertion. Why? Because if you relieve the pressure from the ventricles, their GCS will improve, their ICH score will improve. So don't eliminate their chance of survival. You have to do the maximum in the first 24 to 48 hours, and then decide upon the goal of care. So blood pressure management trials, we have different trials, and the main trials are Interact 1, Interact 2, and Attach 2. Interact 1 was a feasibility trial if it is feasible to decrease the blood pressure in cerebral hemorrhages. There is no harm in cerebral blood perfusion pressure. Yes, there is no harm. It was feasible. So then after that, they conduct an Interact 2. Interact 2, the primary outcome for that was the death or major disability at 90 days. And the goals of the blood pressure was from less than 140, less than 140, from 18, less than 140. And with the decreasing the blood pressure less than 40, they didn't achieve their primary outcome, but they achieved the secondary outcome, which is the hematoma expansion. Attached to trials also failed to show significant difference between primary outcome, which is death and disability at 3 months. But they have two groups right now. The one group is from 110 to 139, and the other group from 140 to 179, like dropping the blood pressure less than 180 and dropping the blood pressure less than 140, the two groups. And they saw more of renal impairment and renal complication in patients. They drop it to less than 110. That's why their studies wasn't that significant in improve or in empowering the decreasing of blood pressure less than 140. So that's why the recommendation is to drop blood pressure below or equal 140, but not reaching 110, because possibly there is a harm on the kidneys if you drop it that fast to 110 in a couple of hours. And part of dropping the blood pressure, we depending on IV medication that is titrable, yes, but you should start the oral hypertensive medication as soon as possible. I know people, when they saw me adding the oral antihypertensive medication in the beginning, they said no, but the recommendation right now, yes. Why? Because it shortens the staying in the ICU, it shortens the cost, so it is cost effectiveness trials. And if you started earlier, you know what's medication that suits your patient, what's the medication that your patient will not respond to. Uh, so this is the blood pressure management. So blood pressure management, the target is 140 and less. The medication we will use, IV medication, that is titrable medication, what's available in your hospital. Nicardipine, I think, is not available in Saudi Arabia, so we will use labetalol. Except if your patient is asthmatic, you can use other like hydralazine. You have to drop the blood pressure as soon as possible, even before the CT scan, if the patient within the window of IV TBA, so you can save a couple of minutes. Dropping the blood pressure will prevent the hematoma expansion, yes, but it will not improve the outcome. Reversible of second cause of hypertension of ICH is coagulation or coagulation diathesis or bleeding diathesis. So if the patient on anticoagulation, you will reverse them. Patient on antiplatelet, you don't give a platelet except the patient is going to OR or their platelet dropped to a devastating stage, and you think this is the rebleeding is relating to the dropping of the platelet. So anticoagulation. So warfarin, we know we will give vitamin K, regardless of the level of the INR, because it is devastating or life-threatening bleed. And you can give also the prothrombin complex concentrate or fresh frozen plasma, and we will compare about both of them later on. Dabigatran, we will have antibody or medication that is reversible, which is the monoclonal antibody, which is iatrozumab. We have the total dose is 5 milligram. You can give it in total and divided doses 2.5 milligram IVQ 10 minutes. And if the ingestion within 2 hours, you can give charcoal if the patient consider dialysis if there is renal failure in these patients, because their elimination time is very prolonged. Factor 10 inhibitors like rivaroxaban, apixaban. There is one on the market that was approved in 2000, I think 18, which is aldenixate alpha. You can give it. You can give also prothrombin complex concentrate. So prothrombin complex concentrate and fresh frozen plasma, what is the difference between them? Prothrombin complex concentrate, we will give the doses. It will be, the dose will be units per kg, and the total dose will be units. It's depending on the INR. The doses will depend on the INR of the patient, and it contains 4 factors: factor 2, factor 9, factor 7, and factor 9, 10, and 7. I'm sorry, 2, 7, 9, and 10. Uh, so, and there is also another marketing product that have only 3 factors of them. Fresh frozen plasma will have all of these, and the volume or the dosing will be fixed like 10 to 15 milligram per kg, depending on patient weight. Not depending on the INR of the patient, not depending, but you, after you give it 20 minutes, you repeat the INR and see if the patient need an extra doses of fresh frozen plasma. The problem with the fresh frozen plasma, it's a large volume, and if patient who are in warfarin for AFib and they have a congestive heart failure, the fresh frozen plasma will be very harmful for them because they will lead to pulmonary edema and congestion. So till now, we don't have prothrombin complex concentrate in our hospital. I don't know when they will be when it will be available. It is a good medication, and it is other thing like favoring prothrombin complex concentrate. It is very fast in action. Fresh frozen plasma will take time. So this could be, you can take it and you can shift to your patient to OR. This will take time to shift your patient to OR. Other reversible agent is tranexamic acid. If the patient have spontaneous ICH related to hypertension without an intraventricular hemorrhage, you can give tranexamic acid. There is a ICH trial too. It is a randomized controlled placebo trial. The primary outcome is the functional status, and they failed to meet their primary outcome, but they meet the volume expansion of the hematoma, like other studies like ATTACH and INTERACT. They failed to improve the functional outcome of their patient, but they improve the hematoma, or they inhibit the hematoma expansion. And the dose of the tranexamic acid is 1 gram intravenously, Q8 hours. So this is, we manage here the primary insult or the primary cause of the ICH. The ICH will not come alone. A hematoma or a volume in the brain may cause a brain edema and mass effect and herniation. And these we have to deal with them as we dealing with any brain edema. As I sent you the article last month, the brain edema was the usual treatment. And the red flag, don't give steroids. Don't give steroids. The harm of steroids in these patients is more than the benefit. Okay, so don't give a steroid. The treatment of brain edema, either mannitol, hypertonic saline, both of them, temporary hyperventilation, elevating the head of the bed, intubate the patient, sedate them, shifting to the OR if they are an OR candidate, and we will go for surgical approach right now. So surgical management of ICH. So we are finishing with the medical management. We manage the blood pressure of the patient. If there is any reversible cause like anticoagulation or bleeding diathesis or coagulation problem, we have to fix this. Anticoagulation, we will reverse each medication with the proper antidote for heparin. I didn't mention, it's protamine sulfate, and you can give it also with enoxaparin. It is partial reversal, it will not be a full reversal. Antiplatelet, we will not give anything except if your patient will go to OR. In aspirin, we will give platelets. In Plavix, we can give also desmopressin. It can help. Surgical management of ICH, it's depending on the location. That's why we say it is infratentorial, supratentorial. Infratentorial, we say it's cerebellum and brainstem. Brainstem, you will not touch them. Bleeds in the brainstem, whatever you do, the situation from the beginning is nasty and misery, you will not do anything. But if the cerebellum, you do suboccipital decompressive craniectomy, you evacuate or you decrease the pressure in the brainstem, you evacuate the hematoma, the patient can survive and can have a good outcome. And we saw this in a couple of patients who came to a surgical ICU before. If there is any decline in the neurological exam, this is the urgency of the surgical management. If the size of the hematoma is more than 3 cm, or it is compressing the brain stem, or if there is hydrocephalus, they will do suboccipital decompressive craniectomy with EVD. Lobar, if the ICH causing mass effect or herniation in severely affected but salvageable patient as a life-saving measures, yes, and we will go for other indication or other trials that go back and forth against or with the craniotomies or decompressive craniotomies for these patients. So this is for cerebellum. The cerebellum is the guidelines is very clear. Any cerebellar hematoma more than 3 cm causing mass effect, hydrocephalus, or more than 3 cm, go for surgery with no further questioning. The lobar or the supratentorial, there is lots of studies that goes either invasive surgical like craniotomy or a decompressive craniectomy, or the minimally invasive, and we will go through them all. Lobar ICH, craniotomy of ICH, uh, the Stitch trial is the initial trial, and it is the trial that if you put any meta-analysis for these patients, any meta-analysis for these patients, for these trials, it will have big impact because this is the largest trial. Stitch trial suggests improved in the outcome of decompressive craniectomy with coma, GCS less than 8, significant midline shift, lobar hematoma, and ICB didn't normalize with medical management. Like this, the candidate for surgical treatment. Any GCS less than 8, significant midline shift, large hematoma, and patient is not improving with medical management. This patient can go to a surgical arm. Stitch trial was craniotomy rather than decompressive craniectomy. Stitch trial is a randomized prospective study looking at effectiveness of early surgery within 24 hours versus initial medical therapy. Initial medical therapy, like you have to control the blood pressure, if there is any reversible for coagulation problem, mannitol and hypertonic saline, and other medical measure for decrease the ICP. Stitch trial didn't show any significant difference in the outcome between the surgical arm and the medical arm. The subgroup analysis shows that superficial hemorrhage less than 2 centimeters from the surface benefit from the evacuation. And they follow them after their evacuation of the hematoma to 6 months. The patient who go to the surgical arm have more functional or better functional outcome after 6 months. Not immediately, not 30, not 90, 6 months. And this is why ICH need an extensive rehab more than the stroke. So if we say Stitch trial is a craniotomy trial. There is no decompressive craniectomy big trial. They are smaller trials and trial that involve couple of patients, like 45 patients eligible for 45 patients, where the retrospectively comparing with patients who managed medically, like 72 patients. And this shows that decompressive craniectomy significantly improved the survival compared to the medical treatment. This is survival, like patient will die and you will prevent the death by taking them to OR and give them give them the functional outcome to be persistent vegetative state. It's okay with you, but you give them the chance to live. So there is no significant improvement in the functional outcome, but they survive. So it is survival thing, like the decompressive craniectomy and stroke patient. This is decompressive craniectomy, and Stitch trial was a craniotomy. Comparison between craniotomy and decompressive craniotomy in supratentorial intracerebral hemorrhage, no significant difference in 30-day mortality between compressive craniotomies or decompressive group. But later on, they said the outcome in 30 days, the functional outcome later on in a 12 months, the functional outcome for the craniotomy group was superior to the decompressive craniectomy group. And till now, it's all of them are smaller trials. Some of them are retrospective trials, and we cannot put our money in retrospective trials most of the time. So we need a randomized control trials to judge what we are doing. This is for the invasive part. We will go for the non-invasive part, which is the MISTY trials and the CLEAR trials. MISTY trials and the CLEAR trials is minimally invasive surgery plus a recombinant tissue plasminogen activator for ICH evacuation. So we thrombolysis is working in both arms right now, in ischemic part and the hemorrhagic part. And how come hemorrhage? How can give an IVTBA in a hemorrhage? Yes, you can give. You will try to put a catheter and evacuate the hematoma, and put a catheter in the ventricle, give an IVTBA, and try to dissolve the hematoma. So you have two catheters, one on the hematoma and the other in the ventricles. Give an IVTBA and wash the IV and wash the dissolving blood from the intraventricular part to your chambers. That's what they do. So it is minimally invasive surgery plus TBA, enhance the survival functional outcome for independence. MISTY trials may benefit ICH patients because of effective removal of the clots that occur to appear to be limited with the limited tissue injury. This clinically significant benefit should be tested in a phase 3, and there is phase 3. These results should be lead to a major change in the practice. Now, the majority of ICH patients don't undergo surgical removal of ICH. So the point of MISTY trial to shift from the surgical invasive part to minimally invasive part. MISTY trials, we will go for 3. There is a clearing, yes, of the hematoma. There is shrinkage of the hematoma. The patient will have faster recovery. And that's what we will see. For moderate intracerebral hemorrhage, MISTY didn't improve the proportion of patients who achieved good response in 300, like in a year of hemorrhage. The procedure was safely adopted in our sample surgeons. Like, it is safe, there is no increase in the hemorrhage. It can help in the functional outcome. In this that was published in the Lancet, they didn't improve the functional outcome in 1 year, but it shortened the ICU stay. So CLEAR 3 is the same. You will clear this is spontaneous intraventricular hemorrhage, non-traumatic intracerebral hemorrhage, volume less than 30 ml, intraventricular hemorrhage obstructing the third and fourth ventricle. There will be both drains, and they will give IV TBA also. TBA, I'm sorry. Patient with intraventricular hemorrhage on routine extraventricular drain irrigation of alteplase didn't substantially improve the functional outcome at modified Rankin score 3 cut compared with irrigation with saline. Protocol-based use alteplase with extraventricular seems to be safe. Future investigation is needed to determine whether a greater frequency of complete intraventricular hemorrhage removal via alteplase produce a good functional outcome. So till now, it will improve the CT scan for the patient, but the functional outcome till now they cannot proved that will be improved for this patient. It helped, but to be honest, it helped to discharge patients from ICUs. So we finished the medical arm, surgical arm if we have surgical procedure to be done, and we will go to dealing with the complication. So the complication could happen earlier, could happen late in this patient. So one of the earliest complication patient could present with it upon their presentation is seizure. If seizure happen, you will treat them. No rule for prophylaxis. Antibiotic medication. 5 to 15 patients will have seizure. Low threshold for continuous EEG. If the patient, patient is comatose and we have small time in hemorrhage, and it's not causing this level of GCS or level of consciousness, so we will have to ask for EEG. Fever, and fever is one of the worst thing to happen to any patient in the ICU, and it is worse to happen in neuro patient because it will drop them down. Why? Because any fever will exacerbate their neurological deficit. Any fever, possibly there is an infection. It was an alarming point if there is any infection. And if there is any infection, these patients will have poor outcome. Should be removed. DVT, the incidence of DVT of these patients is 1 to 15, to 1 to 5, I'm sorry. Prophylactic dose of subcutaneous infractionated heparin or low molecular weight should be started in patient with a stable hematoma within 48 hours. This is the guidelines. If the hematoma is stable 48 hours, or you have 2 repeated CT scan 24-hour apart, that means by default 48 hours, there is no expansion in the hematoma, you should start DVT prophylaxis. Because if you don't start DVT prophylaxis, maybe you will go to start later on the therapeutic dose of DVT, because they have higher chance to have DVT. And like I think 1 year ago, we have one patient who was admitted to the floor. She didn't receive, she had 7 days or 5 to 7 days without DVT prophylaxis, and she developed BE. So these patients are not a kind of patient that you will play with them. So you will have your checklist in these patients. Okay, is there any high ICP symptoms? If I have controlled the blood pressure, yes. Is there any surgical role in this patient? No. Any high ICP symptoms? Yes. There is some mass effect, but it's not surgical. So start mannitol hypertonic saline or any mannitol or hypertonic saline. No need for steroids. No fever. Is there any DVT prophylaxis for this patient? How many days right now? We are in day 3, and the CT scans are fine. There is no expansion of the hematoma. So these patients should receive DVT prophylaxis. DVT prophylaxis. Initially, 24 hours, they will be in the pneumatic boots, mechanical, and then the medication. So, in conclusion, ICH is a heterogeneous disease and it is emergency. Any emergency, the ABC. As we mentioned, we have to deal with a couple of things in patient with ICH, and any medical issue, we have to tackle 3 main principles. I have to stop the primary insult. I have to prevent secondary injuries, and if there is any complication that pops in my face, I have to deal with it. So ABC: control blood pressure, control blood pressure, control blood pressure. Search for etiology. If it is reversible, reverse it. Predict expansion of hematoma and mass effect. Because you cannot sleep in patients who will have dot sign. I'm sorry, who will have dot sign. Prevent or deal with the complication, which is either fever. Okay, you will not treat fever empirically. You will culture them, see if there is any infiltration in the chest X-ray, if there is infection in the urinary tract infection. So treat it. Culture them when they have fever. Try to tackle the cause. Don't blame that's a central fever, because sometimes you blame it's a central fever because of hematoma, yes, and you forget there is a culture that's positive, and patient go into septic shock. Deal with the complication like seizures and DVT. Please prevent DVT. Try to prevent DVT. And this is like putting it all together. Hyperacute phase is the ABC, patient protecting the airways, GCS list more than, not if they are not protecting their airway, like 8 and less. Oxygen saturation should be maintained. They should be maintained normotensive and normoventilation. Like don't drop the PCO2 below 30 in these patients. Like don't hyperventilate them, because prolonged hyperventilation will lead to vasoconstriction initially, and then the autoregulation will be lost, and you will lead to more devastating things. Monitor these patient vitals, standard neurological assessment every hours, NIH score, GCS, and 4 score, as we mentioned in the last lecture. Key thing in the history, and laboratory, like time of onset of symptoms, drug availability, recent surgeries, advanced health directives, if there is like patient is DNR or not, allergies, CBC, electrolytes, BTT, INR, serum glucose, troponin, and toxic screen. Prevention of hematoma expansion, we said manage blood pressure, blood pressure, blood pressure, blood pressure, blood pressure. Correction of coagulopathy is vitamin K, anticoagulation, NOACs, heparin, or low molecular weight antiplatelet. We said we will not give we will not give platelet unless the patient will go to OR. Fibrinolytic agent, as we mentioned in the last lecture, what we will do for these patients is there is any signs or evidence of ICB increasing in the ICB, check and treat the ICB. And ask the neurosurgery if they want to go for surgery upon what we discuss. Imaging, non-contrast CT scan is very helpful. It will give you the location, supratentorial, infratentorial. You will know the volume of the hematoma, the presence of the IVH, if there is any signs of mass effect or herniation, spot sign with the CTA, and will give you a hint about the etiology. When shall I ask? The etiology not identified on CT, non-contrast CTA. So basal ganglion thalami, patient with history of hypertension. Shall I ask for other imaging modalities? No, because no further imaging. The patient, no history of hypertension, and the age is less than 45. I should ask for other modalities. MRV, to give you a hint about it, we will ask, or CTV will ask it for it if we think about sinus thrombosis. And the bleed of sinus thrombosis usually bilateral. Okay, multi-compartmental bilateral. Sometimes nothing in the CT scan, or there is nothing on the MRI or MRA, you will go for digital subtraction imaging, which is the angio. Sometimes you will go for angio because you will see a vascular malformation in here and you want to embolize it, and concept nothing in the angio. So this is your imaging pathway. Consider surgical intervention, as we mentioned, about the early non-surgical neurosurgical consultation for potential cases like consider EVD, insertion in hydrocephalus, ICH location, infratentorial, as we mentioned, this lobar hemorrhage, and supratentorial, as we mentioned, if there is any mass effect superficial less than 2 centimeters from the cortex with a mass effect and patient is clinically deteriorate, you can push your patient. Prevention of secondary injuries, if there is any signs or symptoms of ICB, you have to treat it. If there is any seizure, you have to treat it. If the patient is not waking up, they kept him off sedation for a couple of days, and the hematoma is small, you have to have low threshold for asking for EEG. And the general ICU housekeeping, early internal nutrition, avoid hyponatremia, avoid hyperglycemia or hypoglycemia, maintain normothermia, prevent DVTs and anemia. Complete history and checklist and ICH scoring system for good communication if you want to shift your patient or you ask the neurosurgeon to interfere with your patient. So thank you.